questions and comments during the case, you can ask them. So let's start. Good morning, everybody. Good afternoon, everybody. Welcome to International Teletrauma Grand Rounds. This meeting is going for 14 years to the Pan American Trauma Society, University of Miami, Virginia Commonwealth University. And it's our honor today to have a case presented by the fellows from Ryder Trauma Center. I would like to introduce you Bob Cortez. He's a second-year fellow. He's the one managing this series for this period for the fellows at Ryder. He's going to introduce our panel presenters today, and then going to be moderating the meeting. Thank you, Bob.
Thank you, Dr. Martos. Thanks, everybody. Welcome. So again, as Dr. Martos said, I'm Bobby Cortez, second-year trauma fellow at Ryder Trauma Center. It's my privilege to present Dr. Gareth Gilna, who's joined us here. He's one of our esteemed senior residents at University of Miami, currently in his PGY4 year. So Dr. Gilna got his MD from University of New Mexico School of Medicine. And then after joining us at University of Miami to complete his general surgery training, he actually achieved and accomplished his MPH at U of M with his thesis, which is quite fitting for this case, recognizing risk factors to prevent future suicide attempts in the pediatric population. I've had the privilege of working with Gareth throughout the year, first year, absolutely outstanding resident, and I'm very excited that he was able to put this case together and speak with us. The title of it is The Assault of Self, Managing Multiple Self-Inflicted Stab Wounds. So I'm sure we'll all learn a lot and be a great case. So Gareth, go ahead and get started.
Thanks, Bobby. Pleasure to be here. Let me just share my screen really quickly.
Liliana, are you recording the lecture, please? Be sure the lecture has been recorded.
Kevin, are you there? Is it recording?
Yeah, it says
yes,
recording.
I'm here.
Yes.
Thank
I'm
you.
here. It's recording.
Thank you.
All right. As Dr. Cortez said, my name's Gareth. I'm one of the fourth-year residents here at Jackson Memorial Hospital. We have a case of, and we'll go through the case, and the real discussion that we want to have is the intraoperative management during the initial and second case during the operation. It's a pretty unique case where there was some major decision points that we made, and again, kind of hope that we can stimulate some conversation about what could have been done differently, or what other people's way of thinking would have been during this type of presentation. So I'll get right into it. So while we're in the trauma bay, this was the pre-hospital information that we got from the EMS. It was a 52-year-old female, multiple stab wounds to the neck, chest, and abdomen. When the initial presentation, they said that she had a heart rate of 110, hemodynamically stable, and her GCS was 15, and that was pretty much all the information that we got from our EMS colleagues. When she arrived to the trauma rider bay, her primary survey, she was protecting her airway. She had bilateral breath sounds. She was 100% saturating 100% on room air. Her heart rate was in the 110s to 120s, and throughout her entire initial evaluation, her systolics remained stable in the 130s to 140s. Her GCS was 15. Going on to the adjuncts of her primary survey and moving on to the secondary survey, we did ultrasound her lungs, which showed lung slidings. She had a normal cardiac ultrasound. We saw no pericardial fluid. Her hematocrit was 41. We got an upright chest x-ray, which you can see on the right. There was no pneumothorax that we noted, but we did note kind of the raised hemidiaphragm on the right. And then I'll show kind of a depiction of where all the stab wounds were. There was one to the zone 1 of her left neck, and then there were 6 other stab wounds, all kind of in the thoraco-abdominal region. This left one was above the costophrenic angle, and then the other 5 were in the thoraco-abdominal, but more in the abdominal region. We were able to digitize I suppose that's the best word, digitize the stab wounds, and particularly, can you see my cursor?
Yes.
Yeah, particularly this left stab wound, we could feel that there was penetration through the peritoneum and violated the peritoneum. At this time, the vitals had been unchanged. The patient had no peritonitis. There was no succus, no bleeding, no evisceration. But the violation of the peritoneum was quite large. But again, the patient had remained hemodynamically stable, had not required any blood transfusions. And so I guess this was our first kind of decision-making point. So I wanted to hear from the panel what your what your next move in management would have been.
Okay, we'll turn it over to our panelists for some more discussion and insight and comments. So first up, Dr. Kasim, any comments?
Well, these are self-inflicted stab wounds. And the first thing in a case like this would be to ascertain, is this patient bleeding from any of this area? Because that is where the money is going to be initially. If he is bleeding, say that neck wound or the abdominal wound, the neck wound should be packed. It can be easily packed either with gauze, chemical packing material, or even a polycatheter. You can use almost any modality that you choose to use to stop the bleed. And the second thing would be that she does have a chest stab wound to the left chest, even though the chest X-ray does not show anything like a pneumothorax. At least I would be cognizant of the fact that I may require chest tube insertion if, not if, since the patient is going to go to surgery because the penetration of the violation of the peritoneum in the abdominal cavity. So I think I would very quickly put a chest tube on the left side and then look around to make sure that you have accounted for all the stab wounds, especially in the back area and thigh areas and things like that. Don't overlook anything more. And since the peritoneal cavity has been violated, the patient mandatory has to go to the operating room without any CT scan, etc. This is the case where I would not waste time sending the patient for a CT scan, etc. Thank you.
Thank you, Dr. Kasim. Dr. Stubing, any comments? Oh, Dr. Namayas raising your hand?
Yeah, Bobby. Dr. Kasim, the penetration of the peritoneum is not a mandatory exploration in 2023. I mean, that ended with DPL in the 1960s. So I think that we might have all gotten a little bit confused by the way that Gareth presented it. They went to they planned to go to the OR not because it penetrated the peritoneum, but because the hole was so big, they figured they would have to close it, right? So penetration of the anterior abdomen is just a marker for the need to do something else, whether it's serial observations or whether it's diagnostic peritoneal lavage. But it's not a reason to mandatory explore unless, of course, you're in some environment where there's no ability to do serial exams and, some super austere environment. The most conservative thing is always to operate. But he was going to the OR not because he had violation of the peritoneum. He was going to the OR because the violation of the peritoneum was so big, they were going to have to close it.
Does the size matter? If the violation is so big, can you surmise that there might be injury deep inside?
Well, but that wasn't the point. The point was they have to close it. Whether it's big or small, we don't have data to suggest whether there's something inside. And I just don't want the trainees to walk away saying that if the peritoneum is violated, then you must go to the OR, because that's just absolutely not true.
Thank you, Dr. Moyes, for clarifying. Any other comments, Dr. Stewing?
Yeah, I think you have to think about the different regions of the stab wounds. And I know this patient is mildly tachycardic, but not hypotensive. And if that is due to blood loss, is it externally from the neck, or, is it in the abdomen? I think we don't know at this point. Also, you have to think about pericardial tamponade with the location of one of those stab wounds. So I would do a fast to look for pericardial tamponade. Appears that there's not a significant hemothorax. So if the pericardium is violated, it doesn't look like it's leaking into the left chest. I agree with Dr. Nemayas that there's no absolute indication at this point to operate in the abdomen. Yes, the peritoneum needs to be closed, but sometimes you can do that after a period of serial exams, and then you just do a very small local closure of the fascia. The other thing you need to think about is whether there's diaphragm penetration on the left side, and that's all. Wait for 12 to 24 hours so that you don't have to do some major laparotomy if it can be fixed laparoscopically or something like that. So I think we need to know, is the patient stable enough to wait for that observation period, and is the tachycardia coming from a tamponade versus blood loss somewhere else, and is it getting worse or better, or is it from something else entirely?
Thank you, Dr. Stewing. It's great. Any more comments, Dr. Valenzuela?
Yeah, I agree with the other panelists. I think with where the stab wound of the neck is, if it, from the presentation, does not sound as though there's any hard signs. But you still need to consider whether there's an esophageal injury based on the trajectory. So I would actually consider, if the patient is stable, to at least get a CTA of the neck and chest to make sure that you understand the potential injuries there. And I agree with the abdominal portion that it doesn't necessarily need a scan and serial abdominal exams if the patient is someone you can examine. And I believe they said she was GCS 15, but I don't know what her psychiatrically, if she's appropriate or not.
Understood. Absolutely. Dr. Lenine, anything to add?
Yeah, I agree with everyone. I think stab wounds to the abdomen are like a clinical diagnosis. You're unstable or you have peritonitis, then you need something done. You have the diaphragm to worry about, but that doesn't have to be dealt with right that second. And the stab wound to the neck is, I think, needs to be imaged. There's a recent paper at the AAST about even people with hard signs may benefit from stab wounds imaging prior to anything. I think the one question I would have here is, this lady stabbed herself. And so your exam, you have to be very careful with your exam and whether you can really truly get an accurate exam on this patient. Because if you can't, and she's bleeding or showing, then she could actually deteriorate quickly. So that would be my one worry.
Yes, sir. Thank you. Excellent comments from all the panelists. Thank you. I'll turn it back to you, Gareth.
Yeah, just to kind of address a couple of the things that people said. Pretty much that whole conversation was had with us and our attending and my co-fellow there, or fellow that we were all in the resuscitation bay with. I'm sorry I didn't address the neck earlier. There were no hard signs of any vascular injury or any obvious signs of esophageal or tracheal injury in the neck. It was hemostatic. We did pack it. And then we did do a ultrasound of the heart that showed no pericardial fluid. And again, we did the chest x-ray and looked at the lungs to look for any pneumothorax. We had decided at that time the patient was, saturating 100% on room air, but our thought to put in chest tubes are our suspicion was very high, and if we said at any time if the patient became hypotensive, that we would take the patient or place at least a left-sided, if not bilateral, chest tubes. So ultimately, we kind of, as Dr. Namias alluded to, we went to the operating room. We were concerned because of obviously the fascial and peritoneal penetrance was very large, at least on one of the stab wounds. And so we knew that the patient would necessitate an operation at some point. And we were concerned that there were, and again, this kind of goes against the algorithm for abdominal stab wounds, but there were several that we knew did violate the peritoneum. And so our suspicion for a injury was much higher. So it kind of goes against that algorithm, but the patient was becoming uncooperative with our exams. And so we just felt like the safest thing to do would be to go to the operating room at that time and perform an exploratory laparotomy. And
I'm sorry, Gareth. How did you know it penetrated the peritoneum?
we were able to stick a finger through it.
Okay.
Yeah, so we did just a bedside, and at least one of the stab wounds was probably 4 or 5 centimeters wide, and clearly violated the peritoneum. You could feel the small bowel, and I think it was the small bowel.
Was there any evisceration of the abdominal contents?
There was no evisceration of the abdominal contents, but we, at least kind of the way that we talked about it with the attending, that while there was no small bowel coming out of the wound, that the size of it kind of qualified as evisceration in the mind of the team at the time, just because
Yeah, so Gareth, again, the wound was of such a size that you felt it was going to have to be closed. What Beth said, what Dr. Stubing said, was also, pretty spot on. There was the option, if this were the totally cooperative patient, to close this thing in a, without a laparotomy and then do serial observation. Sounds like they weren't that kind of a patient. So laparotomy to close it was also not unreasonable. It's tough because you have things that you don't have anything that's demanding an operation right now, except the fact that this hole is so big that you're afraid they're going to cough and their guts are going to come out. The risk for injury is not, that's done for hemodynamic instability or peritonitis.
Right.
And the diaphragm you want to look at after a period of observation. This fascial hole you like to close after a period of observation, but you're being denied the luxury of a period of observation because you're afraid the guts are going to come out.
Yeah. So we went to the operating room. The patient was intubated in the operating room. During the induction period, the patient did have transient hypotension. So while that was going on, we did a right-sided chest tube. Even though there was that stab wound to the left thoracoabdominal region with the high riding right diaphragm, the right side, we decided to place the right chest tube first. We had no air or hemothorax or blood come out of the chest tube, so we proceeded with our exploratory laparotomy. Once we had immediate hemoperitoneum. This was a complicated laparotomy because we noted that the patient had a supraumbilical, maybe like 4 or 5 centimeter previous scar. And when we got down to this area, we recognized that the patient had a prior ventral hernia repair with mesh and had dense adhesions from that region. And so we were, at that time, we kind of stopped taking down our continuing the laparotomy inferiorly, because we noted that there were several lacerations to the liver that we were able to see. So we packed that to try to get hemostatic control of the liver. And then we were also able to see our right upper quadrant region and see that there was a laceration of the spleen. So we packed that as well to try to get hemostatic control. During this time period, the patient again became profoundly hypotensive. Their systolics were in the 40s or 50s. MTP was started. We placed a left chest tube as well, which again had no output, no rush of air, no blood. We still, at this point, despite the fact, and it was kind of, we were looking for a cause of the hypotension. There was bleeding around the liver, but it wasn't kind of where the blood is welling in our face and we're having to, evacuate the massive hemoperitoneum. So we did perform a transdiaphragmatic pericardial window, which was negative, just had serous fluid coming out of it. We had to place our hand over the aorta to kind of allow our colleagues to catch up with the MTP. At this point, the patient had become more, her systolics were again now above 90 in the hundreds. They had caught up a little bit, but we were concerned that we were missing an injury somewhere else. We noted that the stab wounds also had gone through both of her rectus muscles on either side, which had active arterial bleeding. So to be able to kind of gain access and get a better vision of this, we continued our laparotomy inferiorly, but to avoid any injury to what we were concerned that bowel was within this, recurrent hernia that had been repaired and had mesh. We had to continue our laparotomy and kind of go around through the rectus muscle, not through the midline, just through this small, it was maybe a 5 or 6 centimeter recurrent hernia and the area where there was mesh, and then continue down. After this, we noted that there was no zone 2 or zone 1 hematomas or zone 3 hematomas, and no obvious bleeding coming from the rest of the abdomen. So
pause you right there, Gareth. Wonderful job. This is obviously a lot of technically challenging steps of the operation here, but just to get systematic about what I'm sure are going to be some great comments from the panelists. The first one that you brought up was, and I think this is something we've encountered at Ryder, where the patients don't read the textbooks, and the first one is you get ready to do your trauma laparotomy and you encounter varying degrees of significant intra-abdominal adhesions. And I think we've seen that, especially over the first year here, more so than my general surgery training. But we'll open up to the panelists, not only for what has been discussed about the case so far, but I'd say the first one is intra-abdominal adhesions in trauma laparotomy, any specific maneuvers and ways to balance that rather than tackling all the adhesions straightforward while allowing the patient to continue to bleed. Is there anything the panelists have learned from encountering these cases? So Dr. Kasim, I'll turn it to you first.
I think you're muted, Dr. Kasim.
Like I said initially, that you need to do a thorough examination of the patient before you actually dive into doing any type of surgery. And at that time, I would have noticed that she has had previous abdominal surgery, although I probably wouldn't know what the surgery all meant. And so I would be cognizant of that fact that I may have to circumvent that, be aware that I'm going to be encountering significant resistance, such as adhesions, etc. And having determined that, my usual approach in cases like this is the midline incision and then go around the area where the hernia is, where the hernia repair was done. That is on elective cases like this, but if it is and life-threatening case, I don't I don't give any concerns to that. I just go through right through the repair and redo it, because saving life is much more important than the previous hernia surgery, in my hands at least. So having done what I plan to do, and the reason why I was suspicious that this case probably requires mandatory procedure is the left upper quadrant incision was very close to the spleen, and not knowing the length of the knife, and I would have been suspicious at that time that I'm going to encounter some injury to the spleen, and he may have lost significant of blood as well. So, and another thing is, during surgery, when the patient is becoming hypotensive, you need to be rather quick and have a wide open eye to see which quadrant he's bleeding from, so that at least I could tampen out that, and have either a paddle or a clamp available that I can put a cross clamp of the aorta near the hiatus for the anesthesiologist to catch up. And in cases like this, I work with the anesthesiologist, tell him that although hypotension is kind of detrimental to the patient, but I do not want the patient to be having a systolic more than 90, ideally between 60 and 90. And because the higher you raise the systolic blood pressure, it's a clot buster.
Thank you, Dr.
It's
Kasim.
it's a difficult case, and then there's a difficult decision that you got to make, but you have to make it rather quickly. And I'm sure that they got this under control. Thank you.
Thank you, sir. Great comments. Dr.
And
Stubbe.
sorry, I forgot to mention this. Dr. Kasim had addressed this before. We did have time. We did feel like we had time, and she was stable enough. We turned her and looked for any other stab wounds before we went to the operating room. So the stab wounds that we saw initially, there was nothing posterior, and so the ones that I showed on the initial presentation were the only injuries that were ever noted.
Thanks, Gareth. Dr. Stubbe, any comments?
Yeah, sorry, I lost connection for a little bit, but the question is, what do you do with a trauma patient with adhesions and you have trouble getting to the problem?
Yeah, any kind of just kind of wanted to throw an additional complexity of the case out there in addition to what's already been done and described by Gareth.
Right. I mean, my first case as a fellow on trauma at Rider was a gunshot through the liver on a guy who had a prior peptic ulcer perforation and a bunch of adhesions. I mean, I think, you just extend incisions as much as you can. Try not to go through, try not to injure more things if there's an area of, adhesions that you can get around. But don't worry about going through mesh, like has been said. Although, I mean, in this context, like that might mean also going through a bunch of bowel and then you have even more injuries. So you have to take it as a case-by-case basis. But there are different incision options, and sometimes, you have to think of those, if plan A doesn't work.
Thank you, Dr. Stubbe. Great. Dr. Valenzuela, any comments?
Yeah, I agree with the bilat. If you have new onset hypertension with the stab injuries that this patient had, I agree with the bilateral chest tubes and doing the transdiaphragmatic pericardial window. If you're suspicious that you're hemorrhaging from the abdomen, which sounds like this is a situation, I agree you can try the supraceliac control of the aorta, Pringle maneuver if you have access to that. And I'm going to throw this out there. I would actually consider a Roboa if you really are concerned of abdominal injuries and you need a little bit more time. I would actually considering Roboa or partial Roboa to try to extend the amount of time to do the extra maneuvers that you may need to do to get access to the abdomen.
Excellent, Dr. Valenzuela. Thank you so much. Dr. Lenine, any comments?
I mean, I don't think there's any like like technique that you can do to avoid problems in this situation. You have to move quickly. I like the idea of a Reboa, actually, if you're really like exsanguinating and the belly is frozen and ton of adhesions, you don't think you can go to the problem. But also you have to accept that maybe some things may get damaged in the melee and you just have to be ready to repair it, you know. I think you got to stop the bleeding primarily. So, you know, I think it's you move quickly, as safely and quickly as you can, but you got to remember always your goal is to stop the bleeding. So the Reboa is a good idea if you really can't get there quickly.
Excellent. Thank you all. Dr. Carter, you on, Dr. Carter?
I am. Can you hear me?
Yes, sir. Yeah, thanks very much. So, yeah, Dr. Carter was in the operating room here, obviously, with Dr. Gilna. Any comments as to, you know, you're at this point at stage in the operation, kind of what was going through your head and what were your concerns and plans to what to do next?
No, it's fascinating to hear all these senior surgeons, you know, commenting with great ideas, honestly. My impression was that once we got through our initial period of profound hemodynamic instability and we were able to catch up with resuscitation and get an extra cooler in the room to be prepared for additional hemodynamic instability, we were able to release the manual supraceliac aortic control and maintain reasonable hemodynamics, and that allowed us to complete the rest of the operation. But if that weren't true, then definitely putting a balloon up would have been a great idea, and it's something I'll tuck away for the next case.
Excellent. All right, turn it back to you, Dr. Gilna.
Yeah, so I guess I kind of got ahead of myself. We did the pericardial window and completed our laparotomy. We performed a splenectomy. We packed the liver with Nunit. And then, as I had mentioned, the stab wounds had transected both rectus muscles, and there was arterial bleeding from both of them. So we had to ligate them both inferiorly and superiorly, which we obviously understood the morbidity of the potential implications for the success of the closure later on. But obviously there was bleeding, and that was unavoidable. At this point, the MTP had slowed down, and as far as we could tell, we had hemorrhage control, but the patient was still hypotensive, acidotic, and was still requiring some transfusions. Again, we had nothing coming out of our chest tubes. We had a negative pericardial window, and so we were still looking for reasons for the patient to be kind of still have this hemodynamic instability. It had obviously improved from previously, but the only thing that we could really think of, we were looking at our liver, and it had appeared to be very congested. It had enlarged, but at this point, there was nothing that was actively bleeding. We moved up to our neck, which we had packed, as I mentioned. We removed it. There was a small area of arterial bleeding, which appeared to us just to be like a perforator from some of the muscles. But because we had active extravasation, we performed a formal neck dissection, extending the incision along the sternocleidomastoid mastoid. We got control of this small arterial bleeding, which again was superficial, and after that there was no active extrav. We were able to visualize the carotid sheath. We saw no hematoma or injury, so we elected not to open up the carotid sheath to explore that any further. On intubation, the anesthesiologist had done it with bronchoscopy. So there was no airway injury noted at that time. But at the time we felt like the patient was too unstable to perform an EGD, so we didn't look at the esophagus at that time. But we felt pretty certain that our hemodynamic instability was not from our neck. So we returned to the abdomen. The liver still appeared more congested. But again, intra-abdominal bleeding had stopped and the patient had begun being on pressors, was hypotensive and getting transfused. So kind of what other people's thoughts would be to do next is another discussion point.
Sure. Before I open it up to the panelists, Dr. Stubing had a great point of getting to whether there was a history of toxic ingestion overdose, SSRI, that can cause profound acidosis, may cloud your clinical picture in the OR. And I think that's an excellent point to bring up and consider when you're in resus, to send a screening panel, for instance, and following that up while you're in the OR. Great points, everyone. I'll turn it back at this point to the panelists. Dr. Kasim, any comments?
Well, there are two reasons why the liver getting congested like this, at least as far as the surgeons are concerned. You know, something wrong with the portal system and something wrong with the hepatic outflow. And having ruled out any portal vein injury or portal vein transaction, having ruled out the hepatic veins are okay, and the short segment of the IVC before it enters the heart is okay, and there's nothing going on, and the liver itself, what not so damaged from the stab wound, you need to think about what possible drug this patient may have taken or has been on before to give rise to something like this. And sometimes, it takes a little longer for hemodynamic status to catch up. And we as surgeons, we are always in a hurry. We want things to get better as quickly as possible. Sometimes you just have to have patience. So what I would have done is I would exercise my patience and yet look for reasons why I'm seeing what I'm seeing in the liver, and perhaps make a couple of phone calls to some wise people who know about liver, and tell them that's what I'm doing and see if they can give me some answers. Those are all the things that I have actually done in real life, because I have worked in remote areas and where things just didn't look right to me, and I always picked up the phone and called somebody. Thank you.
Excellent
I would
comment.
have called the Professor Niamas.
I'm sure we all have. Dr. Stubing, any comments?
Yeah, I think it sounds like, from what I was able to gather with my horrible connection, that there's no ongoing surgical bleeding. I would look for other causes of acidosis, whether the patient is profoundly hypothermic and just needs to be, further resuscitated. If there's any way to do a TEE, or, perhaps there's some, cardiac, insufficiency that could give you, if she's in some kind of, cardiac failure or cardiogenic shock, that could give you the liver sort of congestion as well. But I think at this point, it sounds like there's no ongoing surgical bleeding. And so everywhere you've got a negative, pericardial window, I think the longer you stay in the operating room, maybe the worse it will get, with the patient open and all of that. So if she can get warmed and maybe some other kind of imaging to look for other kinds of shock.
Thank you, Dr. Stubing. Dr. Valenzuela, any comments?
I think if you're uncertain, this is a really interesting case and I appreciate everyone's input. And I think if you are still worried about bleeding, and as trauma surgeons, it's bleeding until proven otherwise, right? Is there a potential and understanding of it a pretty very high resource center, calling in IR to do an on-table angio, just to say, hey, we've looked at every possible things and adequacy of hemorrhage control.
Excellent. Thank you. Dr. Lenine, any comments?
I mean, with stab wounds to the liver, you don't know what it hit necessarily unless you really crack it open, which is not something you need to do most of the time. I mean, so you have to think of angio, like Dr. Valenzuela said. The other thing you can see in like modern trauma resuscitation now with the liver is as the massive transfusion gets blown in through the rapid infuser, the liver will swell up in front of your eyes. And obviously you may need that to maintain blood pressure, but you have to be careful, especially when you have a really bad liver injury, how fast you're running the massive transfusion, because the venous pressure side is directly related to your atrial pressure, and you'll often can't control hemorrhage from a liver when you're blasting blood through the massive transfuser, and you have to slow it down. So you may require some pressors in this situation sometimes. Now, I don't know, the liver doesn't seem like it was bleeding. That's probably not the issue, but I think if you're still unstable with a liver injury, you probably should do an angio.
Thank you, sir. Yeah, wonderful insight from all the panelists. Dr. Carter, any closing comments just from that segment in terms of where you were in the operating room and just hearing what the panelists have said thus far?
No, that was pretty much our line of thinking as well. It's just, we were wondering if there could be cardiogenic shock occurring, possibly toxic metabolic, but most importantly, our goal is not to let the patient exsanguinate. And so we ended up calling for angio on table, as the panel suggested.
Excellent. Excellent comments all around. Dr. Gilna, back to you.
Yeah, I agree with what Dr. Carter said. We did have, a number of kind of had that same conversation that just happened now. I think something maybe that we could have utilized that our trauma anesthesiologists are quite facile with is a TEE. Well, we called IR, and obviously that is a lengthy procedure that, it takes them time to get set up. And so potentially having a TEE performed while we were waiting for IR to perform their part of the procedure would have been something that we could have considered. So we got the IR angiogram. They found no active extravasation. So after this, the patient still was, I believe they were on 5 of levo, but hadn't had any transfusion requirements up to that point. Again, we had transfusions had stopped at that point. To say the hematocrit was stable. The patient was never hypothermic, but was acidotic. So we packed the liver, placed a temporary abdominal dressing, sent the patient to CT scanner, and then transferred them out to the ICU. We didn't see any other injuries noted on the CT scanner. And then here you can just see the total transfusions that the patient required. We got 4 whole blood, 11 PRBCs, 10 FFP, 3 cryo, and 3 platelet. The workup in the ICU, let me get there, from post-op day 0, the coagulopathy, the acidosis corrected, but the patient still remained hypotensive and despite a stable hematocrit, and remained on levo. I think it says started, but it continued to be on levofed, not necessarily with an increase. I believe the max that she ever was on was 11 of levo, and she was also on a 0.04 of vaso. We did obtain an echo, and this kind of goes to that conversation that what we're discussing, maybe something that we didn't recognize fully is that the patient did have pretty severe cardiac dysfunction. Her EF was 20 to 25%, and with severe also right-sided heart failure. So while the patient was stabilized, we waited until post-op day 2. The patient returned to the OR where she was re-explored, and the liver was hemostatic. No other injuries again were noted. Bowel was run, all of the normal procedures that are done. And then we went forward with an abdominal closure. And at this point, so I guess I'll preface this in saying we had already described where we had to circumvent the midline because of the 4 or 5 centimeter recurrence of her abdominal trauma with that, I mean, we don't know what type of mesh, but a mesh that was in place. The mesh was containing just omentum. It didn't end up containing any bowel, but that, hernia was resected, and then, we wanted to talk about what your techniques for closing the abdomen were. There was not, the abdomen was closable. It wasn't something where we had to do any type of roar device or anything like that for, it was going to close without much tension. But I think in a patient, in all trauma patients, but especially this patient with a high risk of having complications with their closure, we wanted to discuss what your process and what your technique would have been to close the abdomen.
Thank you, Gareth. All right, turn it back to the panelists. Dr. Kasim, any comments?
One of the things that I would have done in the operating room before I go to the ICU, I would have done several liters of warm saline lavage to the abdomen to warm up the liver. There's a fellow in London, his name is Dr. Bloomgard, and he suggests that. I personally have not done it, but in one of the lectures that I heard him talk about the benefit of something like that in a congested liver. So now you have the problem of the abdominal closure, how you're going to close it. I think you have to accept the patient is going to have yet another recurrent hernia and do the best closure you can, even if it is just skin and subcutaneous tissue. And don't become pedantic and do the best closure, and the patient ends up with a compartment syndrome later on, or severe infection. And do the minimum and to get the maximum benefit. That's my idea. Thank you.
Great point, Dr. Kasim. Thank you. Dr. Stubing, any comments?
I'm glad I wasn't there. It sounds very difficult. I think there's several things you have to consider. Time on the operating table is one of them. Whose heart isn't working very well. With that amount of and that heart, I think it's pretty unlikely you're going to close the fascia primarily, especially in an area where a hernia defect has been. You may want to just take the loss and put in like a biologic at that point, if that's accessible to you. It would depend on the peak pressures and that kind of thing. But yeah, I think table is and the current physiology is pretty important. You don't want to spend a long time doing a big fancy closure only to have the patient need to be opened the next day or to have a cardiac event.
Thank you, Dr. Stubing. Dr. Valenzuela, any comments at this point?
No, I agree with Dr. Stubing and Dr. Kasim, and honestly, in really disaster situations, I'm happy if I'll just close the skin if I have to provide coverage and come back and fight another day.
Absolutely, great point. Dr. Lenin, any comments?
No, you close it how it will let you close it. You put a retention closure on the next time you take them back and see if it'll close, but with the hernia mesh there, you may not get the relaxation you would normally get with a tension closure. So, but you should get the belly closed as soon as possible. And I think, the other thing, when they get to the ICU, you really have to evaluate someone like this for poisoning, like people have been commenting. Because that, if there's anything you can do to reverse these toxicity they may have from an ingestion, because that can go on to cause a prolonged problems in this patient.
Yes, sir. Thank you. Great points. Gareth, can you comment on any of those investigations in the ICU? There was also another comment by Dr. Arocha, Takotsubo syndrome to consider. Either of those points investigated further in the ICU? Do you have any info as far as that goes?
No, I don't believe a tox screen was performed, and obviously in retrospect, and then given kind of the deterioration of the patient as far as their cardiac function, and then spoiler alert, she goes into renal failure pretty quickly and is on CVH within post-op day 2 as well. I'm not sure that was investigated thoroughly enough.
I would just say a lot of these patients probably are on some sort of antidepressant.
Yeah.
Most of them have side effects, and most of them have significant toxicities. I can tell you, like, years ago, we had a guy who came in who I think he had stabbed himself, but got came in and arrested. He got a thoracotomy with an aortic cross clamp. They really didn't find any injuries, but it took a very, very long time to get him back. And finally, they had realized he had overdosed on beta blockers, and they had to reverse him to get him to come back. So yeah, obviously there's a whole lot going on, but you have to keep some of these things when the patients aren't responding appropriately in the back of your mind.
Yeah, and I think that's one of the reasons that we wanted to highlight this case is it's obviously very easy to get totally focused on just the trauma, and I don't think we necessarily paid enough attention to the other possible reasons for the patient having hypotension and then later multi-organ system failure.
Back to the closure, Gareth. So what ended up happening? How'd you close?
It was with our call schedule and everything like that, it was I guess I didn't put it here, but it was a different team that did the closure, but they just closed the patient primarily with just the looped PDS running, and then they did close the skin as well with staples, and then they repaired the fascial from the stab wounds. They also repaired those injuries as well with permanent suture.
And just in the interest of time, Gareth, great job so far. Wonderful work. Any quick review or anything you have together at the end to summarize the case or anything you learned?
Yeah, so I guess I'm not sure. I guess we're running out of time, but the reason that I spent so much time on the closure and wanted to bring it up is there has been now a wound. There was a midline wound infection, and then there's also now areas of fascial necrosis and dehiscence. And so that's why I wanted to bring up those points. The patient is still, critically ill and on CVH and candidemic and bacteremic. So obviously is still critically ill. But just wanted to go to other modalities for closing abdomens after open abdomens in patients that have had massive transfusions. There are several papers, and pretty much all of them kind of go to that you need to have a multitude of arsenals within your skill set, rather than, especially in patients that you are worried about being high risk. There's intraperitoneal mesh. A lot of our faculty will just lay a Vicryl, and it's not necessarily for the strength of your closure, but it helps with if you're concerned for dehiscence and that it still is something that can protect the bowel underneath if there is fascial dehiscence. And then retention sutures, like we mentioned. And then there's also evidence showing that wound vacs over leaving the skin open and wound vacking the fascia can actually lead to decreased risks of dehiscence.
Excellent, Gareth. Thank you very much. Thanks all the panelists. I'll have just a minute for some closing comments from our panelists. Any final thoughts, Dr. Kasim?
One of my favorite movies to watch is Heaven Can Wait by Warren Beatty. And in there's a line. It's about probability and outcome. And the days when I get sick, when I'm in bed, I like to watch that movie again and again because I learned quite a bit from that particular movie. So how does that probability and outcome apply to this particular case? You see, the probability is that when you see a case like this, as a surgeon, some surgeon, I look at it to see, now what's the probability this patient is going to give me a headache, one way or the other, with a gaping wound and multiple stab wounds. It's going to be, it is going to be a nightmare. So I want to do the very best to better outcome of the patient and better outcome for myself so I can sleep at night. So even though today I learned from professor that it is not a mandatory, the perineum is violated, I'm not sure about that. I am an older surgeon. I've been in this game for 40 years. And I think sometimes, when we read statistics are just statistics. It may not be applicable to a particular case. And if I were in the trauma bay with this particular patient, and I wouldn't think twice to turning this patient back to the operating room very quickly to find out, if there was any injury, because if there were injury, the probabilities are bad. This is a fantastic case, and Dr. Gilna managed it very, very well, in my opinion. And he went through everything methodically. He thought about the possibility of a cardiac event giving rise to congested liver. So all in all, I learned a lot today from listening to this case. Thank you, thank you, thank you.
Dr. Kasim, great job. Thank you very much for all your comments. Dr. Stubing, any closing comments? Dr. Valenzuela, any closing comments?
No, I would say with the complexity of the case of fascial dehiscence is probably not that much of a surprise in her clinical course. So, but really nice job.
Dr. Lenine, any closing comments?
No, it's a great complicated case. Takes it takes a lot of it's what makes us get our gray hairs to worry about all these things, and the problem's still there. I mean, she's still not better, but at least she has a chance to get better now. And it's tough case.
Dr. Carter, any thoughts as the surgeon in the trenches when this all happened?
No, I think the battle continues, and hopefully we can get her through this.
Thank you, everyone. Dr. Martos, I'll turn it back to you. Thanks to all the panelists, and Dr. Gilna, wonderful job. Great discussion.
Thank you, everybody, for this great case and discussion. And that's the importance of this meeting. You have complex case, and different opinions how to manage the same situation and with the different research that you have throughout the world. Bob, thank you for making this meeting happen. See you all next Monday. Next Monday at 8 a.m. We're going to have a case presented by Ahmad House in Qatar. Please contact Liliana to schedule your case presentation for the next 2 weeks. Thank you, everybody. Hey, Bob, great job. Thank you all.
Thank you. Have a good day, everyone.